Please welcome Dr. Olson.
Thank you. Thank you so much for having me. It's really a pleasure to be here and to support your wonderful organization and VEMBRA. I'm an avid cyclist, as you can see by my tan, and this past weekend I was out cycling with some people who were doing team and training, and they had invited me because two of the ladies, one of which is a breast cancer survivor, have joined my team to ride the Tour de Pink. So I wanted to get to know them a little bit, and so I said, sure, I'll get up at 7 o'clock this morning and come on over. And it was a cool thing because they gather around. These are people who ride. A lot of them have been riding for many, many years, supporting the Leukemia and Lymphoma Society. And they had a little huddle, and one of the ladies shared a story. And her story was about when she was a little girl. She was 5, and her sister was 6. And she became sick one day. And Thursday she got sick. Friday they took her to the doctor. She got admitted to the hospital. And Saturday she died. And her experience was that the doctors really didn't want them to talk about it. They told them, well, tell people that she had anemia because cancer is too scary for people to hear. And she really had the feeling that they really brushed it all under the carpet, that she had the feeling that her sister never existed. And it was a really terrible feeling. This was in the 60s, but it was just horrible. They had no support, no medical support, no financial, no emotional support. And she just said it was like my sister never existed. And things went on, and leukemia touched her family again. And so here she is now, all these years later, still riding for the society that raises money and awareness for that disease. So it just really helped me, kind of inspired me for my comments tonight. So I've been a breast surgeon and a general surgeon here in San Diego at La Jolla for almost 20 years now. Trained in the Navy. Breast cancer is my primary focus, but as a general surgeon I get to do other things, treat other types of cancers, treat other kinds of benign disease. I have another passion, which is robotic surgery, which is like a whole nother talk. I'm old enough to remember the days when we didn't talk about cancer as much. You know, I was growing up as a kid, neighborhood ladies would get cancer or whatnot, and we just didn't talk about it. But I think it's important to mention that and note that in the beginning of my training as a surgeon, things were different. I mean, even just 25 years ago, things were very different. And I remember it was just before I was in residency that we started offering women breast conservation. So they could have a lumpectomy and radiation instead of having to have a mastectomy. Initially it was on trial, then it became mainstream. And that has evolved, you know, in my lifetime. We've come a long way in awareness. I think sometimes I hear people are tired of being aware. We're very aware. People may not realize that many, many young women under 40 get breast cancer. It's predicted that about 12,000 young women will be diagnosed in the next year. That's a lot, and I see them in my practice. In the last few months I've had 2 25-year-olds, 32, 37. This week I had another 37-year-olds. And with that comes all the other ladies that are 45 and 47 and 55. And so it really hits the spectrum. Men get breast cancer. Hopefully you know about that. Not as many. 1/10 of all breast cancers are in men. But we are getting better with our treatments. We've come a long way. We're now treating it better. We're having more targeted treatments. We do still have a long way to go, I think, certainly room to improve, but at least we're talking about it. I think we're doing a better job of supporting it, and we're learning, you know, how to support people better. It wasn't that long ago that most women who were premenopausal would get treated with chemotherapy, even if they didn't have involvement of the lymph nodes. So node-negative women, if they had a certain size, they would get chemotherapy. Now we have a new test that's been out a few years, but we're using it more and more. We're relying on it so that we get an oncotype score on women who have estrogen receptors that are positive. We look at the tumors in these ways, and this test allows us to predict who's going to benefit from chemotherapy the most. We assume that the women who are ER positive are going to take a medicine that down regulates the hormone process. There's numerous options. Tamoxifen is the one that first came on the market, but we have many available now. But this test allows us to predict who's going to benefit from chemo. So instead of giving people chemo based on age and tumor size only, we now have a lot more information to base giving that chemotherapy on, and we know who's going to benefit the most from that. So I think that's a huge improvement. Also in the last year, a test has become available called the Breast Cancer Index. BCI by Biotheranostics is a test that helps us to predict who's going to benefit the most from continuing those medicines that make you feel terrible. One of the things that our patients tell us is that tamoxifen and arimidex and those medicines that treat their cancer give them joint aches and cause some pretty significant side effects. And so there's recently been data that suggests that even continuing that therapy beyond 5 years is beneficial from a cancer perspective. But now, instead of just giving that to everybody, we can look at their tumor characteristics and decide who's going to benefit the most, so that if they have to incur that expense and those side effects, we know it's really going to be beneficial to them. We now take far fewer lymph nodes, and this is something that came to pass as I was just coming into private practice at Scripps. We started doing sentinel lymph node biopsies. So instead of just sweeping the entire axilla and taking all the lymph nodes, which causes lymphedema in about 30% of patients, we can now give an injection before the surgery, target the 1 or 2, sometimes 3 lymph nodes that are draining the breast and would catch the cancer first. And if those are negative, then we know we don't need to do more. So we can really make a difference in terms of potential side effects by doing less, more targeted therapy. There's also been a new trial that came out that helps us with what to do with those lymph nodes and that information. We used to automatically, if it was positive, take more. But the Z11 trial has shown us that in women who are going to get radiation, we may not need to do that. If they have only a small focus, we can probably just share the radiation with the axillary nodes and then avoid the side effect of the axillary node dissection, because unfortunately surgery does cause more damage than the radiation does. So if we can avoid that, it's better for our patients. We actually can offer a lot of women immediate reconstruction. Now, in the last few years, we're even better at saving the nipple and the areolar complex. So we can end up with a pretty amazing looking breast, although we've removed all the breast tissue. Cosmetically, it looks pretty awesome. So that's better. The other thing I'm involved with is the delivery of targeted radiation. It's been an evolving process. We used to give radiation with a little balloon. Some women would get partial radiation. Now we have a machine at Scripps where we can offer intraoperative radiation. I'm anxious to have the ASTRO guidelines, the American Society of Radiation Oncologists guidelines, come out so that off protocol we can offer single fraction. So a woman can come to the operating room with a breast cancer. We remove the cancer, treat her with 1 dose of radiation, and we're done. And she's done. And she leaves, and it's potentially a really great thing. And thankfully we have the Mobitron at Scripps that we're already using, but at this time we're only able to give the boost. So I'm really looking forward to that. What we do in San Diego is pretty awesome, but I've learned that it's not what happens across the nation. What's offered to many women is not what women are offered here. We have tremendous resources, and I think we're in a little bit of a bubble. I am associated with a group called Young Survival Coalition. I'm doing their bike ride in 2 weeks, but through that organization I've realized that there's really an array of breast cancer treatment, and what we do here in San Diego is pretty amazing, and not what a lot of women in the Midwest or in rural communities have access to. So we're in a little bit of a bubble here. I think breast cancer can be overwhelming to patients. They're going to see numerous physicians. They're going to get a lot of information that's complex that they've never heard before. It's my language, but it's something completely foreign to most of my patients. So it's overwhelming. And then I have to ask them, well, what do you want to do? So I advise them, I give them my opinion, but the bottom line is sometimes there's not clear indications about one treatment or the other. And there's great organizations that empower women with information, conferences to go to, blogs, other people that help educate them as they go through the process. Breast cancer goes on for the rest of your life. Even if you don't have it actively, you're worried about it. And little things come up. You have to get your mammograms. It's kind of nerve-wracking. And so when things come up, that's sometimes when these organizations with all the knowledge are really, really helpful. There are many hidden costs involved in being ill, having cancer, having some catastrophic illness, taking time off from work. One of my patients shared with me that even parking was just so outrageous for her situation. She spent over $200 while she was getting chemotherapy on parking. And so it got to the point where her husband couldn't come into the visits, which he really liked because he liked to hear it firsthand, but it was just too much. So he would drop her off and go park somewhere off campus and then come back and pick her up. And there's other expenses, things like personal appearance. Wigs are expensive. You know, I send people to my local community, but sometimes that's a little bit higher than their budget can afford. So we have to have alternative places. Lymphedema garments are expensive. Lymphedema treatment is expensive and time consuming. You have to go, you have to pay parking. Parking's a pain. Breast prosthesis and undergarments, as you know, are pretty expensive. So hopefully we're never going back to where we were. Certainly you guys all know the importance of supporting other people. Imagine if you were the one who got the news that you had breast cancer. Thankfully, cancer is no longer taboo. We're talking about it. We're doing something about it. You're all reaching out. You're raising people up. You're raising up yourselves. And better treatments are coming. More cures are going to happen. Cancer patients are not alone. They don't feel alone. And there's amazing organizations like this one out there. So thank you all for your work, and everything you do is so, so important.